And immunotherapy obviously has been one of the biggest developments in oncology in the last few years, and it's being explored in prostate, kidney, and bladder cancer, but in different ways. So with prostate cancer, I think we're a little bit behind. We need to learn how to make the microenvironment amenable to immunotherapeutic intervention. And we have very little data to go on, but a lot of hypotheses and trials in combination ongoing, looking at biomarkers and combinations. In bladder cancer, immunotherapy represents the first approval of a new agent in decades, and those are the PD-1 and PD-L1 inhibitors in bladder cancer. So that was dramatic for us in 2016 when the first ones were approved. Now that we move beyond that, we're looking at how durable the responses are, and most importantly, how we can change patients who are refractory to these immunotherapies into responders, because we know that responses only occur in about 20% of patients, and generally that's the same group that have long-term benefit from them. But what we've seen, which is great, is some patients with bladder cancer living long, healthy lives free of side effects, which is something we never really could have imagined before. So it has changed the field. It's helped a lot of patients. We want immunotherapy to help more patients in bladder cancer. Ways that we're looking at that are, of course, combination strategies, so chemotherapy, immunotherapy combinations, immunotherapy combinations with IDO inhibitors and with CTLA-4 inhibitors, and then novel agents after immunotherapy doesn't work, like enfortumab vedotin is one that's promising. So that's not specifically an immunotherapy, but we're looking on all those fronts in bladder cancer. In kidney cancer, we have had checkpoint inhibitors approved now for a few years, nivolumab specifically, but we're seeing really interesting data combining nivolumab and ipilimumab and combining PD-1 inhibitors with a TKI inhibitor, specifically axitinib, seems to combine the best. So we're seeing now the results of those phase 3 trials coming out. We saw ipilimumab and nivolumab. That phase 3 trial came out at ESMO. At this meeting, we're going to see the first VEGF PD-L1 combination in phase 3. That's bevacizumab and atezolizumab versus sunitinib. And so from these randomized trials, we can really see the advantage that adding immunotherapy brings to VEGF inhibition, for instance, or adding CTLA-4 therapy brings to PD-1 targeted therapy. So this is where we're seeing really practice-changing phase 3 data. So in kidney, the question is, it's an embarrassment of riches. We have a lot of drugs that work. Which one do we use first? How can we sequence these to give each patient the longest survival? And ideally, for some of them, achieve close to cure or treatment-free survival. Right now, it's a minority of patients. We're hoping to expand that.